Misha Feaster, Mike Gibson coming to you live from ACC 2026. And Misha, you are talking about something near and dear to my heart that I've been studying for, 35 years now. Patency in the setting of ST elevation MI. And oldie but goodie, you gave heparin before the person got to the cath lab. What did you find?
Well, we treated 600 patients. We randomized for one-to-one ratio in the field, so at first medical contact. And what we found was 16% absolute difference of the patency of infarct-related arteries. So 43% of patients that got heparin at first medical contact had a patent infarct-related artery when they got to the coronary angiography, and 27% of patients that did not get heparin had a patent infarct-related artery.
And how much heparin did you give? Did you give a fixed dose or was it weight adjusted?
It was weight adjusted. It was 70 to 100 international units per kilo based on the current guidelines for PCI.
And I assume this was all intravenous.
Yes, yes, this was intravenous, one bolus of heparin.
And was there any additional bleeding with that approach
No,
or the same?
the primary safety endpoint was bleeding, and it was non-significant difference between the groups.
How about efficacy? Was there any difference in recurrent MI or infarct size? Did you look at any of that?
We had our primary endpoint was actually the patent artery on coronary angiography. We had secondary, as one of the secondary endpoints was troponin level at 24 hours, which was significantly lower in the treatment group. But for any other, there was no difference in 30-day mortality or 1 year mortality. But of course, the study was not designed to look at that. So
Sure. Excellent. How often are people giving heparin, Misha, before they get to the hospital?
in Slovenia, we did that before. And this was the reason why we noticed when we were comparing our results with in another study, we saw that we have more patent infarct-related arteries at initial coronary angiography as in other countries, and that's why we were looking into what we did differently. I think the base was the Dynami 2 trial, which also gave heparin in the field before coronary angiography.
Yeah. Well, congratulations. A few things have improved patency. 2B3 inhibitors that gave extra bleeding, except the new sub-Q one that I studied. I got more arteries open without excess bleeding. Here you're showing heparin does it. Lytics in the field, tough to do, gives you a risk of ICH. But it looks like both heparin and a sub-Q 2B3 inhibitor may be a couple of ways to get those arteries open. Misha, thanks for joining us today.
Thank you very much for having me.